Our second talker today is Dr. Jonathon Parkinson. He's a neurosurgeon at Royal North Shore Hospital and North Shore Private Hospital. And Jonathon will talk to us today about, is a repeat craniotomy and resection feasible? Thank you.
Okay, thanks Marina, and thanks to everyone for coming. All right, well, thanks again for the opportunity to speak. I'd also like to acknowledge that everyone who's sort of put today on, particularly between this collaboration between BTAA and the Brain Cancer Group, but also Ramsay Healthcare for the use of the space and everyone else who's contributed. My talk today is about repeat craniotomy in the context of tumour relapse or progression or whatever language we want to use. As a surgeon, we're always tend to be involved with brain tumour patients at the start. Often people come into emergency or to our office with a problem with a scan, and that we become involved. And most of the time we can work out what's going on when we first see the patient, work out what the tumour is or what it's most likely to be, and therefore what the treatment needs to be, and that can be largely from the scans. And these are all quite simple MRI scans, T1 weighted post-gadolinium scans that show a variety of different tumours that are that even looking at these we have a sort of a primary kind of provisional diagnosis. And then there are other types of tumours, and these are all examples of meningiomas. I'll cover meningioma a little bit because that's obviously another important type of brain tumour aside from glioma, which has been the focus of most of what this session is about. But even looking at all of these scans, by and large, I can predict what these are before we even start. So the question then becomes, if we know that there's what these tumours are, then what's the role of surgery even to begin with, before a tumour relapses? And I'll talk about these principles and then apply them to the situation where we have progression or relapse of a tumour. There's a few reasons to operate. This is a good example of some of the equipment we use, a microscope and frameless stereotaxy to help us make the surgery as safe as we can. But the main reason for us to the main reasons for us to operate are as listed there. Firstly, we're often in a situation where people have symptoms, we have headaches, we have mass effect. In fact, we can even have the situation where people are in danger because of raised intracranial pressure, which left untreated can have serious consequences. So we may have a role as surgeons to reduce the pressure on a particular area of the brain or the pressure overall. The second role for surgery is what we call cytoreduction, which is where we reduce the number of cells involved with the tumour, therefore giving less of a target for further treatments to treat. But the most important reason really is to find out what's going on. And I'll come back, obviously talk about this in the context of relapse, but really up front, whilst we have a best guess of what things look like on an MRI, it really is, and even with some quite advanced MRIs and PET scans as well, the main reason for us to operate is to find out what's going on. And that's a reflection of this. This is a table of some of all of the sorts of brain tumours that we see, and we can, we need to categorise these tumours so we can know what the best treatment is. But fundamentally what that does is that really, I guess, categorises tumours into two main sort of types. Ones that are localised, that surgery can cure, and that's obviously one of the main reasons to operate is to cure these tumours. And again, talking about meningioma, that's very, very relevant. Or do we have a more diffuse tumour? And that's, again, with respect to glioma, this situation where, yes, we may see a lump of tumour, but that there are cells infiltrating into the brain. And then these tumours are the ones that we analyse even more closely with all sorts of various molecular markers that many of you will have heard of, and that Michael referred to a little in his talk, with IDH mutation and all sorts of various different subtypes, so that we can, again, tailor the treatment that we do based upon that. And that's, of course, again, very important when we're talking about treatment at relapse, and we'll be hearing about that from various other speakers today. But the concept here that's most important when we think about surgery is that whilst we do have this lump of tumour, we've seen in studies that there's tumour extending beyond the margin of that lump, and then even as far as the other side of the brain. And the most important factor there is then therefore knowing that surgery as such for diffuse glioma is never curative as such. We might be able to control tumours for a very long time, but we do know we'll be leaving cells behind. And that's why we have to look at the effectiveness of other treatments and then be prepared for whether or not further surgery may be appropriate. And again, all of this comes down to, first of all, with the initial surgery, but then at relapse, how this looks and where it is. You know, many of these tumours that we're seeing here are in parts of the brain that if we were to embark on any surgical treatment, then the complications associated with that would be unacceptable. Whereas some of these ones that are more sort of superficial lumps, we might be able to remove that with minimal chance of any side effects. So, you know, what we do often end up with this picture where we do have, you know, a tumour that's deep in the brain, crossing over to both sides of the brain, and where we know we can't remove this with surgery. So we have to work out the best balance of aggressiveness of surgery and the likelihood of other treatments succeeding. So going back to how do these principles apply when we get to the point of tumour relapse or tumour progression? Again, they still apply. So we talk about decompression, reducing mass effect and raising intracranial pressure, right? Now, we'll have a lot more information at the point of relapse because we'll usually know what we're dealing with in terms of what type of tumour this is and what the molecular abnormalities are and what the likely sensitivity of other treatments is. So, and whilst there are some medications and drugs which we'll hear about that are helpful to reduce intracranial pressure or reduce the pressure effects, sometimes surgery is what's needed. And as Dr. Back alluded to in his talk, with that series of patients, of the 400 or so patients where we'd done surgery relatively early post-treatment, it was because of mass effect or intracranial pressure that could not be, raised intracranial pressure that could not be controlled with medications. Again, there's this concept of reducing the tumour cell burden, and then finally there is this concept of diagnosis and again knowing what's going on, knowing whether this is truly progression and or if it is these treatment effects that we see and what the implications of that might be in the medium to long term. So here's an example of a patient who initially had this tumour here, had surgery. It was in a fairly what we call eloquent area of the brain, close to his speech control area. This surgery was done awake. We removed a decent amount of the tumour. He went on and had treatment. 1 month after the treatment, the MRI looks like this, but about 18 months after, it looked more like this. Okay. He had a PET scan at that time, which again showed this area of uptake in and around where we can see the MRI abnormality. And again, Dr. Back talked about the type of dynamic PET scans that we do, but this was indeterminate with type 1. This was a type 2 curve. Just again, this is all just sort of fine print of how we analyse this, which is something that's not clear whether it's treatment change or tumour recurrence. So he went on and had further surgery to remove that, which showed that this was mostly treatment change. So when we think, what are some of the variables that are in our mind when we think about whether or not a repeat craniotomy may be not only feasible, but I guess more appropriate? First of all, the pathology, like we've talked about, how likely it is that the tumour will be able to be controlled. So if there's, and that also comes down to what I've put there as interval since treatment. So if it is a tumour that we know is relatively slow growing, and it may be years or even decades since the initial diagnosis, we're more likely to consider surgery because we are more likely to be able to control the tumour with a further operation. The most important thing is always going to be tumour location and where that is. I have a couple of examples to go through with that. Patient status, we always talk about performance status, and this is really a reflection of how well someone is with the tumour and with the tumour progressing, and of course with other medical problems that you might have. So how well you're likely to tolerate treatment. And then finally, of course, other treatment options, okay, which is something that we've kind of been going through and will continue to go through over the morning. This is an example of a patient whose initial tumour, and this is sort of, I guess, as good a reflection in over a decade of being a neurosurgeon that I have of tumour being, glioma being a diffuse disease, right? This is the same patient, same pathology here in January, here in August. Literally the opposite corner of the brain. And that's how we know that this is a diffuse problem. This is outside the treatment field of the radiation, so it's very unlikely to be what we call treatment effect, as Professor Back showed in his talk. And this patient had a craniotomy and removal of this area. This patient had started with what's looks like quite the lump of tumour here, but when his tumour recurred, it was much more diffuse and going into these more vital deep parts of the brain, what we call white matter tracts, where that we again know this is an area that we operate. There's a high chance of being some sort of complication. So this patient did not go on and have further surgery. This patient had this quite large tumour that was all through here with some areas that looked a bit more aggressive inside it. She had a resection of a large amount of that based on some of the pre-op factors like the patient's age, gender, where the tumour was located. We thought this was likely to be a tumour that would respond to treatment, so we erred on the side of caution with her initial surgery and didn't do as extensive removal as was possible. There was this residual tumour here in front of and pushing on this part of the brain called the brain stem. This is during radiation. 6 months post-radiation, you can see that area, that white area is starting to shrink. It's all but gone 12 months after, and you can see that the shape of this has also changed. And even out to 3 years, there's no evidence of tumour there. But at about 5 years, and again, starting to get into this area that's more deep in the brain, near these white matter tracts, there was more change. Now, knowing that this was a type of tumour that was likely to respond to chemotherapy, as well as the fact that surgery here was likely to be risky, this patient went on and had further chemotherapy. So that's an example of a few patients in whom their tumour has relapsed or progressed, and we've had some various different treatment approaches with surgery featuring as part of that. We change tack now slightly to meningioma, and again a couple of different meningioma scenarios. This is another important area of brain tumours that we see. These are all patients with meningiomas who initially had surgery with a view to being to getting basically a complete removal of the tumour. But then knowing that there's different types of meningioma and that these different types of meningioma have different risks of recurrence. And again, we talk about the grade, low grade, to more intermediate or high grade. All these grade 1 tumours we almost always treat with surgery alone. Atypical meningiomas or these other grade 2 types, sometimes it's surgery alone, sometimes radiation, whereas the grade 3 meningiomas will almost always have radiation treatment afterwards. This is an example of a patient with a so-called malignant meningioma, which is a grade 3 tumour. Her initial scan looked like this, with this lump. That was removed. 3.5 years after surgery, it looked like this. Over another year or so, it started to progress. A particular type of PET scan called dotatate showed that this was avid, so there was a treatment that can target that. that controlled things for another year or so, year and a half, or 2 years really, at which point things had continued to progress, and so she had a repeat resection. This is mostly blood rather than it being the enhancement after surgery, and then another year or so afterwards. So this was a good example of a combination of treatments that we could use, surgery ultimately being part of it as well, to try and control relapsing or recurrent tumour. And in fact, we're finding with more of these meningioma type tumours, this is the same patient in two different areas. What we're often doing now is actually debulking the tumour. So this is the tumour here, indenting on the brain stem, and then there's some that actually extends. This is the carotid artery right down here. It's extending through this structure called the cavernous sinus, which is a very dangerous part to operate on. We're able to remove the bulk of this tumour that's indenting on the brainstem, but intentionally leaving some in the cavernous sinus here, again, carotid artery running just there, knowing that we do have other treatments that are possible rather than for further surgery. So summary, repeat craniotomy it's always an option, and it's always something we consider. What we have to think about is the goals of that, what the goals of repeat surgery would be, how they relate to goals of initial surgery. They're very similar, but figuring out tumour factors in terms of type of tumour, how long it's taken to recur, how successful surgery is likely to be, and patient factors, how well a patient is, and also what other treatments are available. But again, it comes back to, as Michael talked about, the role of the multidisciplinary team, where we talk about these things together and talk about what each of us can offer and work out as a unit what the best treatment is. But of course, things just continue to evolve, and as more treatments come online and as surgery becomes safer, there'll be a lot of discussion, and that's why we need to continue to work as a group. Thank you for the opportunity to speak, and again, as we've talked about, write down your questions and you'll have the opportunity shortly. Cheers.